Clinical Pearls, brought to you by Medicom Oncology.
Welcome to Managing MDS. My name is Rami Komrokji, and I'm Professor of Oncologic Sciences and Clinical Director in the Malignant Hematology Department at the Moffitt Cancer Center in Tampa, Florida. So a frequent question I get asked typically are, what are the tests that we obtain upfront at time of diagnosis of MDS, myelodysplastic syndrome? And I think this is a good question, and there are obviously two parts, whether the diagnosis is established or we are working the patient for diagnosis of MDS. So if we are working the patient, obviously we want to rule out the other causes of cytopenias and macrocytic anemia, or what's considered the differential diagnosis for MDS. But if the diagnosis is established, there are certain information we want to get that are important for the patient's staging and treatment and prognosis. So we make sure that obviously we obtain a bone marrow aspirate and biopsy on those patients. Cytogenetics are crucial, and nowadays, at least at time of diagnosis, we obtain data on somatic mutations by ordering next-gen sequencing, whether on peripheral blood or bone marrow. So obviously the value of the bone marrow aspirate and biopsy is to get accurate estimate of the percentage of the blasts, the presence of the dysplasia, which is important to classify the MDS and assess the risk. The cytogenetics are very crucial in also risk assessment. We have standard fluorescence in situ hybridization or FISH testing for MDS. Those can be useful in certain cases if there is no mitotic activities. In patients with deletion 5 or 7, sometimes we tend to see more detected on the FISH than regular cytogenetics. However, those could be also false positive sometimes, so one should be careful assessing, especially if the percentage of the positive cells detected on the FISH is low. The flow cytometry could be a helpful test on the bone marrow to identify the blasts. However, the word of caution there is always that the flow cytometry blast estimates are probably either underestimation or overestimation of the blast percentage. And finally, the somatic mutation data is complementary. It can help in the diagnosis, but obviously it has a very established role now in establishing risk stratification in addition to the clinical models. So in terms of, obviously, once we go with the differential diagnosis testing needed, I think it's very crucial to get the bone marrow aspirate biopsy, including cytogenetics, and nowadays integrating somatic mutations.
Don't forget to subscribe to the Medicom Oncology podcast channel for more clinical pearls. And be sure to visit managingmds.com for more practice resources.